Good morning, and thank you. It's great to be here. I am at the Kaiser Family Foundation, so it's especially nice to welcome you here. And this is the first time, by the way, that I've seen our beautiful new audiovisual equipment, and it's especially gorgeous, so I just want to do a shout out for our beautiful equipment, and I'm glad that you all are here to experience it. Thank you, Amy, and thank you to all of you. I think we are all here in these uncertain times with a sort of a common interest and concern for how will our healthcare system respond to the needs of patients. And I'm going to talk specifically about high-need patients and people on Medicare. And then I also want to get a little bit into some of the policy issues that are in our environment and creating this uncertainty, just to have a sense of sort of what's the environment in which we're all working as we think about solutions throughout the day. So just beginning at the beginning, when we think about high need, I think there's so many different ways we can define the high need population. In my particular case, I was looking at the Medicare population and thinking about, well, high need, we really can define high need in so many different ways. Sometimes we talk about people with functional impairments. There are people who also tend to use a lot of medical services. I think a lot about people with cognitive impairments because I think about how is it that they are going to manage in a complex healthcare system. How are they working in terms of adherence and non-adherence, a pretty big issue for people with cognitive impairments. How are they choosing their plans? How will they get through? And there's, of course, the interaction between cognitive and other health problems. There's chronic conditions. There's fair poor health. I also include here people who are dually eligible for Medicare and Medicaid. This is a group of very low-income people on Medicare who have very high needs and account for a disproportionate share of both Medicare and Medicaid spending. And I sort of stop with this population. It's about 1 in 5 people on Medicare because it's sort of a setup for myself later because with all the discussion around what may happen to Medicaid, it is a group of high-need people on Medicare who have a lot at stake in what's happening in the forthcoming debate. But we can also think about high need in terms of social risk factors. We can think about social isolation and what that means in terms of people in need, people who are living alone. Here at Kaiser, we think a lot about economic security because it ties very closely to affordability. And what you can see here is half of all people on Medicare live on an income of about $24,000 or less. And I think that's an important number to remember and to keep in mind. You all are going to be talking a lot about the high cost of medication. So you can see as a setup when you have half of all people with an income of $24,000 or less, and many of them are not eligible for low-income assistance, it's a significant concern when they get either one high-priced drug, a specialty drug, or maybe multiple medications that they can ill afford. By the way, median savings is $64,000. So when you think about medication costs, that can consume a lot of that $64,000, and many people think that they have their savings in the bank for something like a long-term care risk. And of course, it doesn't go very far when you're thinking about a nursing home expense. We think about high need also in terms of affordability when it comes to medical care. And even with Medicare, what you can see here is that people on Medicare have relatively high out-of-pocket costs, and it varies by condition. This isn't terribly surprising, for example, that people with Alzheimer's disease have, on average, high out-of-pocket costs. If we looked at people in nursing homes, of course, it would be substantially higher, even though Medicaid does help people with nursing home care if they have very low incomes. By the way, this slide was done with 2010 data, I'm embarrassed to say. We do have more current data and we'll be updating it. I think once we start to see the effects of some of the specialty drugs that have come to market, we will see that there are people who may not represent a large share of the Medicare population, but they do have substantial out-of-pocket costs. And so I think, had we seen hepatitis C, for example, in 2014 and 2014, it would look somewhat different. Why do people have such high out-of-pocket costs on Medicare? Well, Medicare is good as far as it goes, but here's the important thing in terms of drugs. There's no out-of-pocket limit on drugs that are taking incident to physician services. So those are Part B drugs. There's no out-of-pocket limit. And Part D, even though there's a catastrophic threshold, there's not a hard limit. So as you'll see in a minute, and you'll see later from other research I know you're going to be seeing, without an actual hard out-of-pocket limit, people do incur significant out-of-pocket costs for their prescriptions unless they have really good supplemental coverage, at least on the Part B side. And when they do have supplemental coverage, people are paying premiums for that, and that's why you see the orange premium segment of the bar, because people are paying for Medigap and employer coverage, and then they're still paying cost sharing, and then there are other services. We did some work a few years ago looking at out-of-pocket spending for drugs, certain drugs covered under Part D, and really the purpose, what we were struck by in the results was how high the out-of-pocket spending can be, both because of the so-called donut hole, the coverage gap, but also because there's no actual limit on out-of-pocket spending. There's no hard cap. Once people reach the catastrophic threshold, they're still paying 5% for their prescription drugs, and 5% of a big number is still a big number. And remember, we're talking about people who have, at the median, $24,000 in income. So just as a refresher here on that Part D sort of oddly designed benefit, there is a deductible. There's a portion where this is the standard benefit design, and I should say, I don't think there is not a single plan in America that looks like this, but this is the standard from which they can vary. There's the deductible, and most plans do have a deductible. There's a portion of the out-of-pocket portion of the benefit where the plan pays some and the individual pays some. And as you know, as you probably know, rather than have a 75%, 25% coinsurance arrangement, there are tiers. So people are paying, there are 2 tiers for generics, and there are 2 tiers for brands, and then there's a tier for specialty drugs. So tier placement really, really matters for people. And that's something that people we know do not look at most people don't look at when they're choosing a plan. And it can vary from year to year. And in any event, so then they reach the initial coverage limit. And then there's this odd thing called the donut hole, which I'm sure you know about, which is being filled as a result of the ACA slowly and gradually until 2020. And then there's the catastrophic threshold, above which the individual pays 5%. And what we're seeing is more and more spending occurring now above the catastrophic threshold, which has big implications for Medicare spending and big implications for consumer spending. So I want to shift gears just a little bit and talk about the policy outlook for people with high needs with a primary focus on Medicare. So we were talking about uncertainty. I think there's a lot of uncertainty in terms of what the future holds. Lower prices, in terms of Medicare, raising the age of eligibility. I'm going to go through each of these, ACA repeal. There's just a lot we do not know. There's a lot of disagreement within the policy environment, and the outcome of these policy decisions have enormous implications for patients. I am going to focus mainly on Medicare, but as you read there was an article in the paper just this morning about what ACA repeal means today, or the concerns about ACA repeal, replace, rebuild, remodel for people with cancer and other serious diseases who were able to access coverage as a result of the ACA. So this is an issue not just for people on Medicare, maybe not primarily for people on Medicare, but including people on Medicare. So one way to approach this is to think about the Congress in conjunction with the administration. And we've been looking at and tracking what has President Trump been saying and what has Speaker Ryan been saying. And to be fair, there are big differences, and to be fair, it's a moving target. So it's not easy to say exactly where the Congress is and where the president is, but in general, as you can see from this slide, there's not a lot of agreement, at least in what we've heard so far. In terms of repeal, the president has said we're going to repeal the whole thing, but there's not been a lot of focus on Medicare if you listen very carefully. And I'll get back to that. With prices, the president's been talking a lot about it, but Paul Ryan has not, and so on and so forth. So let's kind of go through the different aspects of this. Repeal the ACA. Well, the president had said during the campaign he wanted to repeal all of the ACA. Let's just undo the whole thing. Well, I think as we get closer, we're seeing that's not really what seems to be on the table. And if you look at Paul Ryan's A Better Way, they were silent on the issue of the donut hole and the preventive benefits, and they seem to retain the savings. Nobody likes IPAB, the Independent Payment Advisory Board, so that seems to be something that could be on the chopping block. Taxes are on the table. There are a lot of provisions that are in the ACA that directly affect Medicare. So while people think about this as an issue that is not about Medicare, it really is about Medicare in pretty important ways. There were benefit improvements that are significant, the donut hole and preventive benefits. There are a lot of payment reductions, which you might remember was quite controversial at the time, in terms of reductions in payments to hospitals and plans, Medicare Advantage plans. There are new revenues, income-related premiums, payroll tax increase for high earners, fees, delivery system reforms, which could be very important, by the way, to high-need people, depending on if they can get it right, and that's a work in progress. There's the Independent Payment Advisory Board, which every time I think about it, I almost think it must have like horns because people think of it as the devil. And then I think a broad point is if all this stuff was repealed, Medicare spending would increase by $800 billion. So that's why I suspect, and I'm not a fortune teller, but I suspect these things will not be repealed. And if they are, there will be a lot of tension. You've already heard the hospitals talking about, hey, wait a minute, we agreed to these payment reductions thinking that we would have all these people who were previously uninsured come in with health insurance. So that gets pretty precarious in terms of what changes in coverage could mean for the Medicare savings. And really, the ACA was a carefully constructed political compromise puzzle. And taking out some of the pieces has the potential to really unravel some of the agreements that made it possible in the first place, making it actually harder to do the rebuilding that people are talking about have happened. There's interest, for example, in repealing the Medicare tax on high earners, which you may have heard about. That in and of itself would reduce revenues by $130 billion. So that's real money, and that affects the Medicare Trust Fund. And when you affect the Medicare Trust Fund, you bring it to insolvency sooner, and that creates an environment, a sense of crisis sooner, which could lead to other changes. So there are a lot of things. We're keeping our eye on lots of balls, and I think it really matters a whole lot in terms of what the next few years will look like. Reducing drug prices. Now, this is something I know you all will spend a lot of time talking about today, and it's very important that you're talking about it today. I have no idea what the future holds in terms of policy in this area. As you can see here, the president, we're like reading the tea leaves. The president does keep talking about doing something about drug prices. The language is general. We don't know specifically what he has in mind, but even as recently as I think it was this month, he's had a meeting with the pharmaceutical industry. His press secretary, yes, he's for it, and I think the question is, what's the it? What does the bidding mean? What's the negotiations mean? Will there be any action? As you could see, let me just back up again, if I can. The Congress really has not taken much action in this area. There's nothing in A Better Way that even speaks to pharmaceutical pricing. So there's some question as to, even if the president moves forward, what will the Congress do? The public is really enthusiastic about having the government engage in this issue. Now, this is a general question, and we have asked other general questions about, do you support having the government involved in various ways to lower drug prices? And almost any way we ask the question, people say yes, 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 and it's Democrats, Independents, and Republicans. This doesn't do argument testing, and we know that argument testing can erode support, but it does give you a sense of the level of sort of public concern, maybe outrage, frustration, which is why I think it's so great that you all are here talking about possible solutions. There are so many Medicare policy broad options that are on the table. I don't know when they're going to come up. I don't know how they're going to come up, but they never really go away. So I think it's just important to talk about them very briefly. There's the idea of premium support, which Dan sort of alluded to when he talked about vouchers. This is the idea of giving people a defined contribution for their Medicare, whether they're in a private plan or in a Medicare Advantage plan. This is a complicated proposal. It sounds really simple the way I described it, but it would have very uneven effects across the country. I don't know that they want to move forward on this. At least this year, the president has said he doesn't want to do much on Medicare. We'll have to see. Raising the age of eligibility, the president hasn't taken a position, but Paul Ryan in the House has supported it numerous times. Changing cost-sharing rules, this is kind of a complicated issue for people with high needs, because what the idea in a nutshell is to simplify Medicare, create one deductible instead of two for Parts A and B, create uniform cost sharing, which would simplify things greatly, and create an out-of-pocket limit, which would be a huge help to people with catastrophic expenses. However, there are a lot of distributional effects, and there are a lot of winners and losers, so every time Congress has come close to this, they've sort of backed away. Here's why, just very quickly. Medicare Part A has a deductible that's more than $1,000. And Part B's deductible is about $150. If you sort of combine the two and create a deductible of $600, the people who pay the high deductible will be very grateful, but they're only 20% of the population. The people who only go to the doctor and don't go to the hospital, who are paying a deductible of $150, will see their deductible rise a lot, and they will not be particularly grateful. So that's the dilemma. Unless Congress says, okay, we're not going to do it in a budget neutral way, we're just going to provide catastrophic protection, which, by the way, would level the playing field between Medicare Advantage plans and traditional Medicare, because Medicare HMOs and PPOs are required to have an out-of-pocket limit, and traditional Medicare doesn't have it. Restricting Medigap coverage is something that is of interest. And then let me just stop on this last one, allowing private contracting between doctors and patients. I think this is something that is worth paying attention to. The idea here is to make it easier for physicians to enter into private contracts with patients. This is something that Secretary Price is very enthusiastic about. There's a demonstration in a better way that would allow this to happen. In essence, what this means is today doctors can privately contract, but if they do that, they do it for all their patients. They waive any Medicare payments, and the patient has to waive any Medicare reimbursement. This would ease up on the restrictions to make it easier for doctors to do private contracts with some but not all of their patients. My concern with this is, just to put this out there, is that it could unravel the financial protections for people in Medicare, which have been in place for decades, which limit the amount that doctors can charge them, so that people have some assurance when they go to their doctors that they know what they're going to pay, and it's not crazy surprise bills, because Medicare sets fees and most doctors accept these fees. So I think this is something to watch, because it's conceivable to see how this would be appealing to physicians, because there would be no limit on the amount that they could charge their patients, and it could create serious cost burdens for patients. So just going back to the biggest policy option that people have been talking about, which is premium support. Again, I don't know that this is something on the table this year, but I do think it is an idea that has been around for a while, so I wouldn't be surprised if we hear about it again. The public is not there yet. In order to get people to sort of move toward premium support, I think policymakers have a heavy lift in terms of convincing people that they will not be worse off as a result. But again, my own guess is I don't see that as happening in the immediate future. Finally, I want to talk a little bit about Medicaid block grants because, as I said in the beginning, some of the highest need people on Medicare are those with very low incomes who are also covered by Medicaid. A big question, as you can see here, both President Trump and Speaker Ryan have said they are supportive of block grants. And in essence, this is the idea of constraining the growth in federal spending and at the same time giving states more flexibility to manage their budgets. This is an idea that is being actively discussed. I guess of all the ideas that I've just gone through, this is the one that really is on the table. And there are just big questions out there in terms of what will block grants mean, how will the dollars be set, how will the dollars grow over time, and what flexibility will states have that could impact the highest need people on Medicare and the highest need people who are not on Medicaid in terms of eligibility, in terms of services, in terms of the drugs that are covered under Medicaid. All of these are big, outstanding questions that have important implications for the people that I know you care so deeply about. I know I just said finally, but really finally. I've been talking so much about Medicare, but obviously when we're thinking about the needs of people who have significant illnesses and take expensive medications and have problems affording their care, there is tremendous uncertainty as to what will happen with the non-Medicare population. And that's obviously the issue on people's minds. I think we will see how that discussion unfolds in the next couple of months. It's not at all clear, to me at least, with that crystal ball where that discussion is going. But as we saw in the Washington Post this morning, people with high needs, significant needs, are anxious. And I think the test of our healthcare system is how well it serves people with significant needs. And I think we are all here to try to make that work as well as it can. And I look forward to the discussion. Thank you very much. We have a few minutes for questions, if anybody has any questions.
Could you just say a little bit more about this sort of fall off or erosion with regard to block grants? Are you saying that the block grant system is kind of too not flexible enough to account for perturbation in the overall economy and increases in healthcare costs? I mean, how would the block grant amounts be set so that they would be insufficiently flexible to account for those other changes you talked about?
Did everybody hear the question? The question, okay, so basically the question is how will the block grant be structured and what will the implication, what are the implications of how it's structured? We don't have the answer to that question. I'm showing, I don't know the answer. So this is a conceptually what can happen. If the idea of a block grant is ultimately to constrain the growth in federal spending, then you have a path that could grow like this, and you can have spending that grows like this. If spending is constrained by some kind of factor that doesn't keep up with healthcare costs, then there could be a gap, and that's what I'm illustrating. Over time, that grows, where either states will have to work some magic in order to operate more efficiently, or there will be cuts. But until there's a formula on the table, and there's not, it's very, for those of you who have seen the House plan, they're sort of saying costs will be constrained, but it's not clear at all how that'll be constrained. And I think there's a lot that needs to be negotiated for each of the states, because they're starting at different baselines. There's a lot of complexity to that question, but the answer to your question will have important implications for people who are served by Medicaid.
Hi, I'm Mary Richards. Thanks so much. This was a great presentation. I'm curious about your out-of-pocket costs. One of the things that folks with multiple chronic conditions, and especially those with also activities of daily living that are impaired, functional limitations, is this idea that there are certain pockets of expenditures that are considered in different ways through an economic lens and through the lens of when politicians and policymakers are looking at spending. So your chart that showed our out-of-pocket expenditures includes things like long-term care, but not in every case that we're thinking about these things from a policy lens do we include the universe of out-of-pocket costs that patients experience. So as we're entering this uncertain period, can you talk a little bit about ways in which that sort of overall patient experience, the actual out-of-pocket costs, not limited by the buckets in which policymakers think of things, but rather through the lens of the consumer and patient experience, how is it that we start articulating some of those things in a better way? How is it that we start thinking about those overall costs as being the starting point rather than having to sort of force our way into that broader conversation?
That's a great question. Yeah, in some ways we look at out-of-pocket costs and we're constrained by what survey data tell us, but we've also looked at it in other ways. We've looked at it, for example, in terms of family budgets. And it's not just the individual who has the expense. Often it's multi-generations, right? So you have children, adult children taking care of their children and their parents. There was actually just an extraordinary piece that someone wrote, Lynn Feinberg is her name, and she talked about writing about caring for her mother, I think it was, and the cost that she and her sister incur because they need to and they want to. And I think pulling that all together would tell a richer story in terms of what it means for people. There's also the issue of employment challenges, so people have to, not work. Some people are fortunate enough to have salaries and can take off a day without losing their income, but plenty of people can't. So there are those kinds of costs. There are costs of sort of the daily costs that are hard to quantify, but if you have to travel and you're low income and you need to get to another part of town and you have to take a couple of buses to get there and again give up a day to get to a clinic, that's a cost that is hard to quantify, but in real terms it matters a whole lot. And the cost of transportation, I've learned, for example, here in DC, but next door in Baltimore where there's not good public transportation, can mean that people don't get the care they need because they can't get to where they need to get.
Hi, this is Jalpa Doshi from the University of Pennsylvania. Tricia, if you could just comment on for the audience here, because we live in an environment right now where there are so many sound bites in the media, and policymakers often talk about Medicare is going broke, it's going to be bankrupt, when really that's not the case. And if you could just kind of shed some light on that, that would be great.
Thank you, Jalpa. Well, right, so Medicare has a trust fund for Part, Medicare's got this Part A, it's got a Part B, and it's got a Part D. And the only part of Medicare that even can go broke, and even it cannot go broke, is Part A. And so at the moment, the Medicare Trust Fund is actually in pretty good shape. It's solvent through 2028. Now, I don't want to sugarcoat this issue. We have an aging population. There is a need to finance care for an aging population. But at the moment, there's not an urgent crisis as we've seen in the past. In 1995, the trust fund was projected to be insolvent 6 years later in 2001. So that was a much more urgent situation. That said, if the ACA is repealed and the payroll taxes are repealed and the spending goes up, that will jeopardized. That will put the trust fund in greater, bring it to insolvency sooner because Medicare spending would rise more rapidly and revenues would go down. But for now, it's not really, it is not a crisis environment today. Great. Oh, there's one more.
Elisa Paul, with the District Policy Group. Question about one of the proposals in the Better Way agenda. There's a great emphasis on health savings accounts and high deductible health plans. What do we know today about how HSAs and high deductible health plans work or don't work for high need patients?
Well, I would not say I'm an expert on that question. I will say that Medicare years ago offered MSAs, which were sort of a companion idea, and they were very unpopular. And I think one of the reasons they were unpopular is because people want security. And people, when they look to their insurance, they're not really looking, I mean, some people are looking for some of the tax benefits that would come from health savings accounts and medical savings accounts. But I think in general, people are looking to have help with their health care costs and are looking for insurance that will soften the blow when they have a high, they encounter a medical professional and there's a high expense. Thank you so much.